In this updated video, I will be reviewing the epidemiology of COVID-19 as of October 17, 2020. All data to date continues to support infection spread by respiratory secretions. Close contacts inhale droplets or aerosol associated with coughing or sneezing, as well as when talking and even when breathing. Droplets can also land on surfaces where they can survive for hours to days. Infected surface particles are often called fomites, and for SARS-CoV-2 fomites have proved to be a rare route of spread, and absolute proof of fomite spread has not been published. Droplets usually do not project beyond 2 meters or 6 feet when someone speaks or coughs. However, a powerful sneeze can project droplets longer distances. The size of the droplets varies, and when talking, coughing, or sneezing, we may produce a population of small particles under 5 microns in size called aerosols, and these fine particles can stay in the air for up to 3 hours. Singing and certain procedures such as intubation are known to generate larger amounts of aerosol. This mode of spread is thought to explain outbreaks in bars, restaurants, churches, and indoor malls. Recent studies now find that asymptomatic or pre-symptomatic infections make up a very significant percentage of cases. On the Diamond Princess cruise ship, over 6 individuals had positive tests for the virus, and 18% were asymptomatic. More recent studies now estimate that 40 to 60% of those who are infected are either pre-symptomatic or asymptomatic. Children and adolescents are more likely to have minimal symptoms. There are also several reports of superspreaders. One of the most notorious examples is Case 31 from South Korea. This 35-year-old Chinese woman traveled from Wuhan, China to Daegu, South Korea, where she visited a megachurch twice, as well as visited a hospital, and while febrile, ate at a buffet before she was diagnosed. Tracing determined that she had come into contact with over 1,160 people. It is likely these superspreaders generate more aerosol. The virus can also be found in stool, but is difficult to culture, and no cases of transmission by this route have been reported. To date, perinatal transmission is rare, but has been reported. Tracing studies reveal that an infected host can infect 2 to 2.7 others. This number is termed the R sub 0 or R naught, and this virus is one of the most highly infectious agents ever reported. Its efficiency of spread varies depending on the degree of crowding. For example, in New York City, the R sub 0 before shelter in place was instituted was up to 5.0. In-depth analysis now reveals that individuals who are infected vary with regards to their ability to spread the infection. The 80-20 rule applies. That is, 20% of those infected account for over 80% of the infections. Therefore, each superspreader on average would be expected to infect 10 to 30 individuals. Why 10 to 20% of infected individuals become superspreaders while 80% fail to spread the infection is not known. However, superspreaders are thought to have a higher concentration of the virus in their secretions, up to billions, that is 10 to the 9th, or even a trillion, 10 to the 12th, viral particles per ml. Strategies to control the spread of infection should focus on identifying these superspreaders and quickly isolating them. But more about this issue in the revised video on prevention in Module 2. The majority of cases are acquired by close contact in family settings. Current estimates are that 10% of close contacts develop the disease. 80-85% of infections are contracted within families, family clusters. Other settings include the megachurch in South Korea with over 1,200 cases, cruise ships, sporting events, bars, restaurants, and gyms. Other large gatherings can also be a problem. One of the most publicized recent superspreader events occurred at the White House during the announcement of the nominee for the Supreme Court Justice. As shown in these pictures, people sat close together without masks and also socialized in a closed space, again without masks. This behavior resulted in a point source outbreak of at least 32 infections, beginning 4 days after the September 26th event. The bar graph shows the number of participants who became infected over time. The first case was identified 4 days after the event, the number of infected participants peaking with 10 cases 6 days after the event on October 2nd, and the last 2 cases were identified 18 days after exposure. As countries have begun to open up, bars, coffee shops, restaurants, and gyms, they have become major sites of spread. As this figure in the CDC MMWR Morbidity and Mortality Weekly Report of September 11th revealed, those who ate at restaurants had a 2.8 times higher risk of contracting the virus and a 3.9-fold higher risk if they went to a bar or coffee shop. When it comes to these locations, masks need to be removed during eating and drinking and usually are closed, poorly ventilated spaces with increased risk of containing infectious aerosol clouds. Visiting gyms or churches was associated with a modest but not statistically significant increased risk of 1.6-fold, as shown in this figure. Points to the right of the line indicate increased risk, and points to the left decreased risk. The brackets indicate the error bars or range of potential variation. As you see, for churches and gyms, these error bars vary widely, extending to below 1, making conclusions about these spaces less definitive. In the early phase of the epidemic in both China and Italy, a large portion of nosocomial transmission occurred through contacts between clinicians and visitors with no or mild symptoms of COVID-19. A number of healthcare professionals also contracted the virus in New York City. In addition to doctors and nurses, support staff who were not provided with adequate PPE became ill. Healthcare professionals must beware and remember Dr. Cece. I will be discussing how caregivers can protect themselves in a video in Module 2. When it comes to who is infected, this virus is an equal opportunity promoter. Everyone appears to be equally susceptible, with the possible exception of children under 10. Males and females are infected with nearly the same frequency. However, males and older adults tend to develop more severe disease, but more about this in the videos on clinical manifestations. Our understanding of how the virus infects humans described in the first video on pathogenesis is supported by studies of viral counts in the nasopharynx and throat over time. Soon after being infected, 1 to 2 days before the onset of symptoms, as well as during the first 3 to 4 days of symptoms, the counts are very high, 10 to the 6th to 10 to the 12th. And these patients are most infectious during this time period. Some individuals shed the virus RNA for many weeks. However, live virus has not been cultured beyond 9 days after the onset of symptoms. To summarize the content of this video, transmission is predominantly by droplets and aerosols. Contaminated surfaces are likely to play a minor role. Beware of the asymptomatic superspreader. Rapid spread from person to person occurs predominantly in families and less commonly spread in large gatherings, cruise ships, and closed public spaces, including restaurants, coffee houses, and bars and gyms, with an R sub-zero of 2 to 2.7. However, 10 to 20% of those infected are primarily responsible for spreading the infection to others, on average each infecting 10 to 30 individuals. This is why larger gatherings should be avoided. If there is a super spreader in the room, as recently occurred in the U.S. White House, a large outbreak is likely. With the exception of children less than 10, all individuals are infected equally. Individuals are infectious 2 days before and 3 to 4 days after the onset of symptoms, and their secretions can contain very high concentrations of virus, billions to a trillion viral particles per ml.